Good morning, folks. Tony Canavan here. We're almost ready to get underway, just a little after 11. But if it's okay, I'm going to allow another minute or so to allow one or two more people to join us, just to give them a chance. Okay, so just bear with us and we'll get started shortly. Thanks, folks. Okay, good morning again to people that have just joined us, and there will be people that will be joining us over the next few minutes over the course of this. My name is Tony Canavan. I'm the Regional Executive Officer for the West and the Northwest. And I'm really grateful to everybody for turning up in such huge numbers. We had a very significant number of people registered for the webinar this morning, and the volume of people that have turned up is very, very significant. So thank you for that. It certainly reflects an interest that exists across all of our staff in what we're doing or what we're trying to do in establishing the regional health area. And our aim over the next hour, or maybe a little more than an hour, is to try and to explain that, to explain where we're at right now with the rollout of the regional health area, to explain a little bit about what we expect to happen over the next 5 months. In particular, there's a period there of 5 months that I think we need to understand. And then I think maybe most importantly, maybe to hear questions from yourselves insofar as that's possible, and to provide you with answers insofar as we can to those questions. The reason I say insofar as it's possible is because we now have over 600 people on the webinar currently. So I think if everybody was even to ask a brief question, we'd be here for a very long time. But we will do our very best to answer whatever questions we can in the spirit of having a two-way interaction, one where we're explaining to some extent what's happening, but also where we're listening to the questions that you have. I've said we on a few occasions. The we is myself, Tony Canavan, Regional Executive Officer for the region, but I'm also joined on the call by a number of the members of the Regional Health Area Management team. With me on the call, we have a number of our IHA managers, including Mary Ward and Cosgrove. John Fitzmaurice will be along shortly, and Dermot Monaghan will be along shortly as well. Both of them are tied up on other business just for the next few minutes or so. We also have Anya McNamara, Dr. Anya McNamara, who is our Area Director of Public Health, joining us on the call, and we will have others as well. What I'm trying to do, insofar as I can, is to keep this as informal as possible, but keep it somewhat structured as well, so that that we manage to get through the business from one end to the next, and that you feel at the end of it that you're somewhat better informed about where things are at. So with that in mind, I have prepared a few slides, which I'll share with you shortly now on the screen. And those slides will be shared out with all of you, and will be available to people. And we're also that something that was asked and the question that was answered, or maybe there are colleagues that cannot make it onto the webinar or attend the webinar here that you would want to share it with, and that you want to give them the benefit of seeing what was said. So, all right, if that's okay, what we might do is, if my technical ability is up to it now, I'm going to share my screen and we'll get going with a brief presentation. And as I say, we'll allow as much time as we possibly can then for questions from yourselves. So just bear with me. And I'm hoping at this stage that everybody can see that screen. So The date of this, good, I'm getting lots of thumbs up. That's great. Thanks for that feedback, everybody. Thank you. So the date that's on this presentation is the 18th of October. And it's one that I used a couple of weeks ago just to bring some staff members up to speed with what was happening. And not a lot actually has changed in that interim period. I think most people that are on the call will remember to some extent where we've come from. So if we start off and we say that since 2015 we've had community healthcare organisations across the country, 9 in total, and the country was divided geographically on that basis. So in our region we would have had Community Healthcare West, which comprised counties Galway, Mayo, and Roscommon. But we were also a significant part of CHO1, which was counties Donegal, Sligo, Leitrim, Cavan, and Monaghan. So that was the previous arrangement, and it existed from 2015 up till very recent times. But also working in parallel with that, we also had hospital groups, and depending on which way you looked at it, we had either 6 or 7 hospital groups across the whole country. On this side of the country, we had Sailta, and again, I'm guessing that most people on the call will be familiar with Sailta. It comprised Letterkenny, Sligo, Castlebar, Portjunkler, Roscommon, and the Galway hospitals. But there were 5 other similar hospital groups across the country and CHI, so in total 7. And that was how we had organised our structures, our health services, our public health services across the country. We had that combination of CHOs and hospital groups. And so the formation of the regions is about bringing those structures together. And the 1st of October was a really important date for us on that journey. Because at that point we stood down the existing CHO structures and the existing hospital group structures, and in its place the regional health area management teams took over responsibility for the delivery of public health services in those geographies. So then when we look at our region, and again, I'm sure that most people are aware of this already, but just in case for those that aren't, when we look at our region, the geography that we cover includes now counties Donegal, Sligo, Leitrim, Roscommon, Galway, Mayo, and a part of West Cavan. And in doing so, it reflects very much the arrangement that we had previously under the Sailta Group, and it reflects a division of CHO1. And of course, all of Community Healthcare West is entirely contained within that new region. So for us, in many respects, on this side of the country, in the west and in the northwest, there isn't a significant change in how we are structuring our services in that way. What we've established at this point, though, is the regional executive officer post. And so I've been around now in this role since the beginning of March. And then since the 1st of October, we have established the Integrated Health Area Manager, and I've introduced you to a number of those. So the Integrated Health Area Managers in our regions are Anne Cosgrove, who covers counties Galway and Roscommon and the health services contained within that. We have Mary Ward, who covers County Mayo. We have John Fitzmaurice, who covers counties Sligo and Leitrim and West Cavan and a part of South Donegal. And we have Dermot Monaghan, who is the IHA manager for all of the remainder of Donegal. And all of those, so we have 4 IHAs and 4 IHA managers. But they're part of a broader integrated health area, our regional health area management team, and which also includes the Director of Public Health, Anya McNamara, whom I introduced you to earlier on. But we also now have a regional clinical director. We have a head of finance, Liam Fogarty. We have a head of HR, Maria Ferguson. We have an e-health director who's appointed into the role on a temporary basis, but we'll be filling that post on a permanent basis in the near future. And we have a number of others as well. We have still a couple of posts to fill within the region, including a regional director of nursing and midwifery, which we would hope to advertise in the near future, and a couple of posts that we have actually advertised already, including a director of planning and performance. So while we have most of the posts of the regional health area management team currently filled, we still have a number of them to fill. I think one of the key things that's worth bearing in mind is that while we are a region and we have been established on the basis that we will take responsibility for the delivery of the public health services for all of the people that are living within that region, we have to do that in a context. And the context is that we're also part of the National Health Service, the National HSE. And so while we have significant autonomy and I suppose the ability to make decisions that are directly relevant to our own population, we also have to be cognizant of the fact that decisions that we take within our region can have implications across the whole country. So we work and we cooperate closely with the other regions, and we work as part of the national HSE as well. And that's an important, I suppose that's an important balancing act in a way, because for the region to be successful, it must be that people like myself and everybody that's working within the region feels that they are responsible for the delivery of the services within the region, and that they have some control and some autonomy in fulfilling and discharging that responsibility. So that's an important balance, especially in the context of us moving from a national HSE where with largely centralized decision making and decision and centralized authority to one that's now more dispersed. So that's part of the journey that we're working our way through. And in fairness, I think we've seen some really good progress on that over the last while. Excuse me. For me, it's also one of the areas where I would hope that that the regions will make a real difference in terms of how care is delivered, and I think that one of the fundamentals to that is about returning that decision making to the regions. And the more that that happens, and the more that we're in control of what happens within our own region, I think the greater the chance, the greater the prospect is that the regionalizations of our health services will be successful and will make a real difference to the health of the population that we're serving. I've said that we've made progress so far, and the detail of some of that progress is provided there. But I guess if I was to pick on a couple of highlights, I'd refer to the key dates that I mentioned earlier on. On the 1st of March, the regional executive officers generally were appointed across the country. I started myself at the beginning of March in this role, and that was important because I guess it allowed us to maybe to start to shape how the regions would look and how they would form and how they would function after that. I think, however, a really important date was the other one that I referred to, which was the 1st of October. And that's when the IHA managers were appointed, and it coincided with the setting up of the regional health area management team. And that allowed us then to be able to stand down the existing structures, the CHOs and the hospital groups. So that was another really, really important date. But it's important to bear in mind, and I do bear this in mind, that these are just milestones on a journey, and it's not a journey that has come to an end yet. It's a journey that we're still on, and that we will be for some time. In other words, we still have lots more work to do in order to fully realise and develop the regions. I mentioned earlier on around the being part of a national HSE structure, and while there's an awful lot in this slide, and it's probably something that's best studied in your own time when you have plenty of it, the important piece for me is around where we fit. And I mean we as in people working within the regions, where we fit within a national HSE overall. At the top of the diagram, we can see the HSE board. The HSE board continues to function and to provide oversight and governance over everything that we do. And so that's a very important overarching part of our governance structure. Reporting directly to the board, we now have the HSE CEO, and again, most people will know Bernard Gloucester as the current CEO, and he's been in post now for 18 months. Reporting then directly to the CEO is the 6 REOs. So in that middle box, that light brown shade, you see the health regions by 6. So I'm one of those people in there, and I report directly to the CEO. That's important, or at least it's important for me, because it means that the structure that I'm working within is very flat. The connectivity between myself and the CEO is direct, and the connectivity between myself and the HSE board is also it's direct. I attend all board meetings, and I'm a full member of the senior leadership team of the HSE. So that's important for me, but I think it's also important for the region. It means that what we are doing, the services that we deliver within this region, are directly connected through me to the CEO, to our board, and to the senior leadership team of the HSE. And that's different to the way things were before. And I think that's a really important difference that hopefully we'll be able to make, that we'll be able to ensure makes a significant difference. Across that line on the management team, you can see all of the people that you would expect on the management team overall, and the key part of it is that the REOs are central to the new senior leadership team, and the rest of the detail I think you can look through in your own time. Then, if you take it and look within our own region, at the structure that we've currently put in place. And I described earlier on the 1st of October being an important date, and I've introduced some of the members of the regional management team that are on the call with us here this morning. That structure is up and running. In fact, we had a regional health area management team meeting this morning just before we joined this call. And if we go through each of the posts, a number of them are filled, but some of them remain vacant. And what we've done is we've included the names of the people that are in those posts that are filled, so that part of the purpose of us doing this here this morning is for you to be clear about who actually is on that team. So if we start with the Regional Clinical Director, that's the second from the left, Professor Pat Nash, who was previously the Chief Clinical Director for the sales group, has been appointed as the Regional Clinical Director and is in post now for a few weeks. We also have the Regional Director of Population and Public Health, Dr. Anya McNamara, who I've introduced to you. We have our 4 IHA managers, all of whom I've introduced to you earlier on. I mentioned our Regional Director of Finance, Liam Fogarty. We also have our Regional Director of People, who's Maria Ferguson. Our Regional e-Health Director is Vincent Jordan. And we also have a Regional Director of Communications and Public Affairs, recently appointed Caroline Crawford. Now, there are a number of posts that are vacant across that line, so we still have to appoint somebody as a Regional Disability Lead. I mentioned earlier on that we've gone out to advertisement for Regional Director of Planning and Performance, and hopefully we'll be recruiting to that post soon. And we also have to fill a post which will be Regional Director of Nursing and Midwifery. And again, hopefully we'll be going out to recruit to that post soon. Not all service areas report directly within the region, and so some things have remained national. One of those areas that has remained national is estates. So Micheál Keneally, who's the regional estates lead, reports into Brian O'Connell, who's the national estates lead for the HSE. Our National Ambulance Service also remains a national service, and so the regional National Ambulance Service lead, JJ McGowan, reports in nationally. However, you can see that there's a dotted line there, which reflects the fact that the role and the functions that Micheál and JJ perform are really, really important to the way we deliver services and our ability to deliver services. And so they're part of the delivery of services within our region. And to reflect that, of course, we have the dotted line, which is very, very helpful. But what's even more helpful and more important is that at the regional health area management team, both Micheál and JJ are active parts of that team. And indeed, as I said, we had a meeting this morning and both were in full attendance and contributing to that. That's really important for me from a service delivery perspective. So we have made good progress. We've rolled out these new structures, but there's a lot of work that's still left to be done. And so for example, it's one thing having a management team in place at regional level, but we also have to have structures at each IHA level that support the delivery of care. We also have to have structures that support the delivery of networks of care that stretch across our whole region, and these would be clinical structures, and again, they would be very important both in terms of knitting our region together and achieving a greater level of integration across our region, but also they would be really, really important in terms of the quality of the care that we provide and in terms of patient safety. So that's another area that we have still have to develop as well. I think I mentioned earlier on about the importance of ownership of our health services, and having that devolved approach which allows the regional health area management team to take ownership of the services is important, but also having an arrangement whereby service users can feel ownership of their services is also really important. So over the next couple of months, hopefully what we will see structures developed within the region that will allow us to engage systematically and in a very functional way with service users so that we can inform our planning and our delivery of care as well. And that'll be another step that we need to take. We're conscious as well that in taking these next steps that we do need to engage with further stakeholders, both within the HSE, people working within the HSE, and indeed people outside of the HSE as well that are impacted by the way we do this. And so we are committed to doing that and to working with people to try and to design and decide on what the next levels will look like and how services will be delivered. And I think one of the things that's most important that I'm reminded of constantly is that we need to do that in the context that services are being delivered today. And if we think about the numbers of patients that are maybe attending their GP, or we think about the people that have been visited already by their home health this morning or by their public health nurse, or we think about people maybe that have gone into the emergency departments in one of our hospitals, or we think about the people that have delivered babies in one of our hospitals, and the many, many thousands of others that interact with our health services every day. It's really important that we all remember, and it's really important that I remind myself that while we are making these changes, care continues, and it has to continue to be delivered at the highest possible level that we can give to patients. It's not enough to be saying to our patients, service users, that when we have our new structure sorted, everything will be fine. Everything, we must continue to do the best that we can every single day while we're making these changes. So that's an important factor, and it does mean that we have to maybe move more slowly than we would otherwise, because we have to be very clear as we go along about what we're doing. One of the things that we've done to try and help us along the way with that is that from the 1st of October, we set ourselves a 5-month period to cover October, November, December, and January and February. That would allow us to do further interaction with all of the stakeholders that I've mentioned previously about what the next layer of management will look like, and particularly being sure that that layer of management is very connected to the delivery of care to patients and to service users, both in hospitals and indeed in the community. So 5 months may seem like a long time, but I'm conscious, as I say, is that 1 month of that has already passed, and while we've made some progress in the last month, we still need to bottom that out. There's a lot of discussions that need to take place, a lot of consultation that needs to take place with people, and then there needs to be decisions made, and we need to roll it out. And again, reflecting the point that I made earlier on, I'm really conscious that we're doing that at a time when we know that our emergency departments are going to become busier. We know that our hospitals are going to become busier, particularly during the months of December and January, and that consequently that all of the health services, both inside and outside of the hospitals, will be very focused on trying to make sure that patients are kept safe in that context. And so trying to make sure that we develop and these new structures while we're also keeping an eye on that is really, really important. I guess one of the things that that I think about really when we were talking about the rollout of the regional health areas is what can we hope to get from this? And I think for me, there's a lot of potential in this. I would refer everybody back to Sláinte Care, which is the 10-year strategy for our health services published in 2017. So there's a little bit to go on that one yet. But I think many of the principles that are contained within Sláinte Care are provided for within this new structure. And the new structure gives us the potential to, I suppose, to bring care closer to bring decision making closer to where people receive care, and to try and ensure that the quality of care improves because of that. So that's one of the fundamentals, I would say, for sure. For me, working within the health service, I really like the idea that decision making and responsibility gets devolved. Now, that works in both ways. If you're responsible for something, you have to be accountable for it as well. But I think that I know, working with colleagues in the health services across this region in particular, that we're up for that. We will see the value in that local decision making and local autonomy, and we are quite prepared to take on the accountability that goes with it. I also think that particularly the ownership of the health services is a really important piece for us to try and advance as well. It'll take us time to get there, because I don't think we're there right now, maybe in some ways and in some pockets, but ensuring that our local communities and people that live within our local communities see their health services as being their health services, that's a really important step, and I think it'll be a key factor in terms of the success or otherwise of these regions. But for me, these are some of the things that the regionalisation of our services promises to us, and some of the reasons why I think it's worth putting in all of this effort and the pain and the suffering and sometimes that comes with the change when you're trying to implement it like that. So anyway, I think I promised at the start of this that I was going to try and keep the speaking part as brief as I could. I've probably gone on a little longer than I intended. What I'd like to do, if possible, if it's okay with everybody, is maybe just throw it open to people to ask questions, and we'll do our best to get the other members of the IHA or the RHA management team to answer questions as well if they're relevant to their areas. And maybe if you just put up your hand, it's the best way for me to see that you're interested in asking a question. And I'm going to try and stop sharing now. Great. So the first hand I see up is from Geraldine McLaughlin. Hi, Geraldine. Do you want to come in with your question? I'm going to ask you, maybe if you don't mind, just try and keep it as brief as you can, and we'll do our best. You're on mute, Geraldine. So now I'm not sure if it's something that I'm doing, or if it's something that Geraldine is doing. One last chance, Geraldine. So, and I'll invite others if they want to put up their hands. Come in. So I'm getting a couple of messages that say you were muted when you joined. Can we unmute you? 1 second now.
Just to flag when everybody should be unmuted, and then they have to unmute themselves again up at the top of their own screen.
1 second now. So they can't speak their questions. Okay. So sorry, Geraldine, apologies for that. Now, I understand now that it's actually not possible for you to unmute yourself. I think everybody was muted at the very start. Yeah, the messages are coming through that you cannot now unmute. So maybe what we might do is we might just look at the chat. If people can put their questions in through the chat, that might be the best way to go.
Tony, we have a number of questions that I can put to you now first, if you can hear me.
I can hear you, yeah.
Yeah.
So yeah, let's go. Let's start with that, Caroline. So just for everybody else's benefit, there I think a number of people sent in questions in advance of the meeting. That's fine. Caroline has them, and maybe we'll take us through some of them now. In the meantime, can I invite people that are in attendance? If you do want to put a question forward, just type it into the chat, and we'll pick it up from there. Caroline, do you want to come in with the first, so please?
Yeah. So Tony, the first question was for yourself, and it was to do with the setting up of the MCAN structure and where that lies now within the new systems.
The MCAN structure.
So the MCAN structure for the hospitals, the networks of care, I suppose, the extension out for networks of care.
Okay, okay, that's grand. Yeah, so I'll do my best to try and keep this brief. So just for everybody that's on the call, the MCANs, that's the Managed Clinical Academic Network. It's a structure that was in place within the SAILTA group, is in place within the SAILTA group, and stretched across all 6 of the hospitals within that group. And so the question is, so what now for the MCAN structure? So we put an interim arrangement in place, which means that those that people that are working within the MCANs, that they have a confirmed reporting line, which goes on from now till the end of this year. And that will give us time to have further engagement with everybody that's involved there on what will happen after the end of this year. And one of the things that is particularly, I suppose, interesting is the possibility of developing networks of care across the region. So there is a proposal that we will have networks of care to cover areas like medicine or older people services, mental health services, women and children services, and so on. Clinical networks of care that will stretch across the whole region and across services, both within the hospitals and within the community. And this would be a further, I suppose, development of clinical directorships. So I guess for people that are working within the MCAN, they have certainty from now to the end of this year, and that'll give us an opportunity to have further discussions to see what shape the networks will take as we go forward, and then we'll take those up with people directly.
Okay. The next question related to HSCPs. And the fact that at the minute with the management team structures you laid out that they say there's no representation, while they represent 25% of the health workforce and are critical in the areas of diagnostic, therapeutic and social care.
Yeah, so this is This is a complicated and it's a tough one because I'm not sure that there's actually really any good or acceptable answer to the question that's asked. So the first thing I would say, without wishing to sound like I'm plow-mossing anybody, is that I fully accept that HSCPs are a really, really important part of our workforce, not just because of the numbers of HSCPs that are currently employed, but also because of the important contribution that they make to care. And so I absolutely believe that HSCPs have a very valuable contribution to make also to the management of services within our region and across our region. When we were looking at this early on in the process, which is probably well over 12 months ago, and we were trying to decide what's the best way to engage with clinicians at the regional level, a number of options were looked at, and while it was initially intended that there would just be one senior clinician, a regional clinical director on the management team, a decision was taken to extend that to include regional director of nursing and midwifery. And I know that for sure that we've had a lot of representations, particularly over the last 6 or 8 weeks, to extend that so that we can also include HSCPs on that. I think the CEO has recently written to one of the representative bodies to advise them that this is something that we're going to have to look at over this 5-month period. And from my own point of view, I'm very happy to engage fully in that process. I absolutely believe that HSCPs have something significant to add.
Following on from that, the next question is, where will health and well-being and health promotion and improvement sit in the new structure?
So that's a little bit more tricky because that's something that we've got to work out with people who are currently working in those areas right now. So currently we have a head of health and wellbeing in the 2 CHOs, in CHO 1 and in Community Healthcare West, and we also have our Department of Public Health also has a function in terms of health and population health and wellbeing as well. So our plan is to use the what remains of the 5 months to engage with heads of service, but also with others as well about how that would look and where it would best sit going forward. If if you were to ask me right now, I think that it needs to be looked at in 2 ways. There has to be that we continue to get the benefits for patients of that direct operational involvement. So that means that I would see health and well-being as being part and parcel of what's delivered at network level, at community healthcare health network level. But I think there's also a strategic piece that has to stretch across the region as well. So getting the balance right would be important. But look, at fundamentally, no decisions have been made about that yet, but we have this 5-month period in which to engage with people in order to make good decisions about it.
And Tony, the final one I think for you here is the prospect of industrial unrest as a result of the restructuring likely to delay the transition timelines?
I don't think so. I think we've engaged very actively with all of the relevant unions, and that engagement is ongoing. We've further engagements planned this week with one of the unions, and next week again with one of the other unions. So my short answer to that is I don't think so. But I suppose one of the things that I would remind myself of is that I understand that when we're making changes like this and changing the ways in which people are working and so on, I understand that that's not straightforward and it creates difficulties for people for sure. But I also remind myself, and I guess we all need to remember this as well, that's what's more important than me or indeed the structure within which I work is the people I work for, and that's the patients and the people to whom we provide care. So right now, if you're to ask me, Caroline, I would say my sense is that people remain focused on trying to do a good job, and they would like to be sure and to be clear that when we implement a new structure that it's going to support them to deliver good care and to continue to do a good job.
We've also a question in here looking for clarity on staff currently on temporary contracts, which have been reduced to 3 monthly contracts at the moment, and will this continue over the coming months?
Well, if it's okay now, I'm going to try and maybe spare people listening to me a little bit. If Maria Maria Ferguson is on, I might ask Maria if you want to come in on this one. But I think we've shifted a little bit on that front. So I don't know, Maria, have you made it onto the call?
Yeah, I'm here, Tony. Hope you can hear me okay.
Do you want to pick up that one in relation to temporary contracts?
Yeah. So I suppose good morning, everybody. And it's lovely to be here and have the opportunity to talk to you all in relation to the temporary contracts. As you know, that's part of our overall approved limit or WT for the region. So the 3 months that has been operating over the last year, I suppose nearly at this stage, or maybe a little bit longer, that arose from the delegation that was given to each of the areas, that we had that approval to extend contracts on a 3-month basis locally. So in the context now of moving forward, as Tony has mentioned, our region has an overall approved number of posts that we can fill. We, over the last number of weeks, have been working very closely with our IHA manager colleagues to set up an approval process, which also encompasses the extension of temporary contracts or renewal of those. So this is something now that there is ongoing and active consideration around. We would hope as we move into the new year and we get our approval for next year in terms of posts, that we will be able to stabilise any of those areas in the context of overall approvals and decisions that are made. So temporary contracts, also temporary hire appointments, and any other positions that we're moving on, that's something that we actively look on. The REO approves, Tony's office takes weekly submissions from ourselves, which are also approved through the IHA managers in each of the regions. So this is something that on a weekly basis we are actively looking at across the whole spectrum of contracts that people hold in the region. If anyone is concerned about their own situation or their own personal situation around contracts and extensions, in the first instance you can raise that through your line manager, and they will then engage with the HR department, and will absolutely commit to coming back very quickly with any answers or clarity that you need in relation to that. So hopefully that's helpful to people.
Thank you, folks. We have a question here just asking, will the information and Q&A be circulated? It is being recorded and this will be circulated to all staff after this meeting. Question, can you confirm if CAMHS Mayo will remain with Galway and Roscommon, or will it return to Mayo Mental Health Service governance? If not yet decided, when are we likely to know?
Yeah, so again, this is one that maybe Anne might want to come in on. I suppose one of the things that I would say is that that part of the benefit of us having this 5-month period is that there are arrangements in place that benefit patients. And before we would change that, we'd want to be sure that what we were heading for was, added some value to that for patients. It's not about maybe what structures suit ourselves, but what would add value in terms of patient services or patient care. Now, so there may well be on the mental health side, particularly on the CAM side, so there's an on-call arrangement and so on that stretches across 3 countries. I don't know, Anne, do you want to come in on that?
Yeah, I suppose I just want to make 1 or 2 comments. I suppose for this interim period of 5 months, can you hear me?
And I'm going to interrupt you there. Your microphone or something seems to be very poor.
Okay, sorry. Am I any better?
Yeah.
You can hear me? Okay.
Yeah.
So just for this interim period, for the until next March, there's no change whatsoever in terms of the governance reporting lines responsibility across Galway, Mayo and Roscommon. Mary Ward, the IHA manager Mayo, and myself covering Galway and Roscommon are working as a single integrated unit. And we have a single management team incorporating all of the heads of service across the community services and the general managers of the hospitals, including QSSI, comms, HR, finance, and it's a fairly significant team with the clinical leadership in terms of the ECDs and mental health. At this point, we do have to work through, and it is a journey, as you mentioned earlier, Tony, in terms of actually determining the structures below the IHA manager role as such. And that's what we'll be working on over the next number of months. But I don't believe that anybody wants to disrupt existing good working practices that are in place. For example, you're on call across the region, etc. And that will be something that we will have to work through over the next 5 months.
So we've another question here, just wondering at what stage will we see the structures following under the IHAs?
Yeah, I might have a go at that one myself, Caroline, if that's okay. So the structure, the management structure under the IHA, if I was being honest, I would say I would have hoped that we would have been in a position to share it about 2 weeks ago, and we haven't been able to do that. And probably the reason for that is because, we're trying to get it right. It's complicated enough. And we're trying to get the balance right between having a flat structure, in other words, that brings people like myself as close as possible to where patient care is delivered, but also a structure that's, I suppose, reasonably robust, that it's capable of, supporting all of the services that we deliver. So getting that balance right is tricky. So it is. I think what we'll, instead of us going out with an with a decided kind of a structure, I think what's far more likely that people will see in the next couple of weeks is that they will see a proposed or a draft structure that we're using to consult with people on and say, look, could this work in our area? When you take into account maybe the scale of the operation that we have, the size of the geography we're dealing with, the complexity of the services that we're provided, could this work? And and to consult properly with people, and then to take the output from that and to retune it on that basis. What I can say for sure is that, going back to what I said about the 5 months, that 5 months started on the 1st of October and it ends on the 3rd of March. For us to be able to implement a new structure on the 3rd of March, we pretty much need to know what we're doing, all of us, by the beginning of January. And in the context of the service pressures that I described earlier on, it means that the number of weeks that we have to work on this together is quite limited, and it's the remainder of the month of November, really into around the middle of December, is that key period. So really over the next while, I think we'll be engaging very intensively with people on that front.
And just following on from that, we have a question on, will the existing 3 PMOs be restructured in the reform?
Well, again, the PMOs, the only thing I could say on that front, though, is that so we currently have a PMO office in the CHO1, and we have one in Community Healthcare West, and we also have one in the Saleto Group. As I said earlier on, CHO1 has been divided now with Cavan and Monaghan, most of Cavan and County Monaghan moving over to a different region. So whatever is happening with that PMO office we have to consider, what the resource requirements might be for Cavan and Monaghan as well. So that definitely has to be part of it. And then outside of that, we also have to think, instead of having 3 separate PMOs, is there something to be gained in terms of the efficiency or the way we deliver care or whatever by bringing those 3 together? So that, I think that's a fairly obvious step, that at least have the 3 PMOs working together as a single unit or working towards being a single unit.
There's another question on the structure of the regional management team, asking, may it broadly vary from region to region across the country?
I don't think it varies. Certainly the number of IHAs varies. So some regions have more and some have less. I think certainly the size of the IHAs, the population within the IHAs, that definitely varies. But then the posts that it's populated with, the Area Director of Public Health, Regional Clinical Director, Regional Director of Nursing and Midwifery, all of those posts that we listed in the organogram earlier on, they should be common across the country, I would think.
We have a few questions in on staffing numbers and whether or not posts that were vacant before the embargo will be made available again to allow gaps to be filled in the service.
So I'm not going to, that would be a hospital pass to Maria. I might ask you maybe to develop it, but I think it's important that I lay out the stall on this one. Maria already pointed out that we are working within a defined head count. So it is important that we work to that. We are doing that currently, and we're working within that overall head count. One of the ways that we're achieving that is that we are not approving posts that became vacant prior to the 1st of January. There are a very small number of exceptions that I have exercised on that front, which absolutely do go directly to the heart of delivery of patient care and safety of patient care and so on. But they are very, very small numbers there. And it wouldn't, I think people should reasonably expect that if a vacancy arose prior to the 1st of January, the likelihood of it being filled is very, very limited.
We have a number of questions about specific services, in particular the Donegal Physical and Sensory Disability Service, and where it sits within the new structure. But I think that it's fair to say that there are a number of people who have put in about specific services and where they sit.
Yeah, so if I was to take disability services, one of the hopes is that that disability services would continue to maintain its own line within the new structure. So going back to the organogram that I showed earlier on, there is a regional director of disability services included in that line, as part of the regional health area management team and reporting into myself. The job description for that post is currently being developed. It hasn't been finalised yet. But when it is, then the question is, and what are the structures that will support that underneath? One of the things that I would say for sure, though, and maybe Mary or indeed Dermot might want to come in on this one, is that that our disability services are delivered in the southern end of the region, they're delivered by the large voluntaries, like suppose Charity or Ability West, Western Care. And in the northern part of our region, they're delivered largely by ourselves, by HSE services. And that's one of the key differences within our region. But the responsibility for them one way or the other for the disability services within a particular health area will be with the IHA manager. While we have a regional director of services for disabilities on the management team, they will be supporting the IHA manager in managing disability services in their area. I don't know if Dermot or if Mary want to come in on that.
Yeah, I suppose, Tony, it'd be fair to say that over the next couple of weeks, all of the 4 IHA managers will be endeavouring to meet with both our voluntary partners who deliver services in disability, but also in other areas, and to visit direct HSE services across the region to familiarise ourselves with those services, to acknowledge the good work and meet the staff, but also to get a handle on the challenges that those services face in order that we can be informed moving forward. So it is a mix, as you say, of direct provision through Section 38s and 39s, but also the direct provision piece. So yeah, that will be our intention as we move forward, to do site visits, meets with staff and service users in relation to how we deliver this integrated care approach across the region.
Thanks, Mary. Caroline, sorry to interrupt you now. I see that John Fitzmaurice has joined us. I know, John, you were tied up at the start of the meeting with some unscheduled care business. I don't know, do you want to maybe just to give us, you're looking after Sligo, Leitrim and West Cavan. Do you want to give us
South Donegal. Better not forget South Donegal, Tony. Yeah.
And South Donegal, good man, thank you.
Yeah, so yeah, apologies for being late, and thanks for the opportunity to be part of today. Yeah, look, the areas that I cover is, as Tony says, Sligo, Leitrim, West Cavan, South Donegal. That will be inclusive of Sligo University Hospital. And look, the priority at the moment is the continuity of services. For me, thankfully, over the last couple of weeks, I've had the opportunity to get out and visit services and meet with people, and that's my intention over the coming weeks and over the coming months, because that's important in the context of learning about the good work that's going on. And I suppose, look, it's heartening to see, for me, the scale and volume of good work that is going on across all of the services in the area that I cover. And I've been fortunate enough as well within that to meet some of the people that use our services as well. So again, that's really important, because that's ultimately what we're here to do. And I think that's the focus for me, I suppose, over the next couple of months, is the learning, but also ensuring that there's a continuity in the way we're delivering our services at the moment. I think that's been a key theme that has come up while this transition period, is to make sure that we maintain the work that's going on. We are heading into a challenging time of year. We all know that. So again, the focus will be trying to keep people safe, keep people well, keep people in their communities, keep people in their homes, and working with services to do that. So look, I look forward to meeting with people. I look forward to working with people in not just in IHA, but across the region. And I look forward to people contributing, I suppose, to hopefully what will be a successful change program. Thanks, Tony.
Thanks, John. Thanks. Dermot Monaghan, I know you were tied up a little bit at the start as well, but do you want to just introduce yourself as well?
Yeah, hi colleagues. Yeah, Dermot Monaghan, AHA manager for Donegal. most of you know me, I've been around that long that I'm probably nearly old furniture, as we describe it at the present moment. In terms of what John just said there, exactly the same from myself, and I'm sure that was repeated by other colleagues, so I'll not just reminisce on that. In terms of the disability services, very clearly we have a different model up in Donegal, and in the Northwest in particular, we're 85% delivered by the HSE, which makes us unique. From a governance point of view, at the current moment, there is an interim executive management team in place. EDL Quinn represents the disability services for the region in that there. In terms of going forward, there'll be two aspects to it. Disabilities will be on the management team for the IHA in Donegal, and will have a key role to play in that, but also that my role as IHA manager is to bring the flavour of disability service delivery model in Donegal to the REO and the RHA, because we all have a different model. There are different pressure points, there are different challenges, there are different opportunities, there are different strengths. But my role is to make sure that is front and centre in the RHA management team. But we have very significant achievements in Donegal and in Sligo Leitrim prior to the changeover. But they're a very key service and very important for the delivery going forward.
Thanks, Trevor. Thank you. Sorry, Carol, I know I'm kind of cutting across you a little bit, but I just see one of the questions or one of the comments that came in relates to an increased focus being placed on prevention and e-health and inequalities. I don't know, Anya McNamara, do you want to just comment on that, or maybe the role of public health as part of the new regions?
Yeah, thanks, Tony. I suppose public health, we've had a reform programme ongoing for the past couple of years, and you know, the aim of that really is to, I suppose, continue some of the work that public health would traditionally try to do. We got a bit subsumed with health protection and COVID as such, but we want to get back into kind of the wider domains, as we call them, in terms of, I suppose, in particular, improving health and looking at the wider determinants of health, and in particular someone that say they're reducing health inequalities, and that is one of the priorities of public health, is kind of to look at that broader area, I suppose, in terms of population-based planning as well, and to kind of expand into that area a little bit more. So that is our hope and intention, and we're working closely then with Tony and the team in terms of, I suppose, getting that population health focus, you know, into the planning of everything we do, to try to reduce those health inequalities and to increase, I suppose, looking at the wider determinants of health, because ultimately, you know, all that, you know, that you do is trying to reduce people getting sick in the first place. So it's back to the old adage, prevention is better than cure. So I suppose that's what I'll be trying to advocate strongly for within terms of the service. And then as well to look at stuff that we can do in terms of population data as well, to provide that to people in a little bit more useful information, I suppose, as well, or to signpost them to where they can actually access that for the regions, and down to a small population area we can get as well. So happy to work with people in terms of that. Thanks, Tony.
Thanks, Tanya, for a pleasure. Thank you. Any more questions, Caroline, for us there that you want to?
There's a question here on the term. I suppose that this is part of people mixing between community and hospital now, but the term CHN has been used. Can you outline what CHN means and consists of?
CHN, is it, Caroline?
Yes.
So again, I might ask maybe John Fitz, or maybe Mary might be a good person here, but Community Healthcare Network. Yeah. So just by way of kind of general explanation, going back to the map that we showed earlier on, if we've our region broken down into counties within each county, and people that are working currently in the community will understand this, we have divided the counties down by networks of care, by networks, community healthcare networks. So it's a geographical division with a defined population within that area and a team looking after that area. Mary, do you want to do a better job than me now of describing what a CHN is?
I know, I think you've done pretty good there, Tony, but it stands for Community Healthcare Network. It's made up of a number of primary care teams. It has operational responsibility for a number of services within a defined population, and it has a network manager with that operational responsibility. working very closely with the head of discipline who provides the clinical governance over the respective disciplines such as speech and language, physio, OT, social work. A number of other services then work alongside the CHN, such as public health nursing, dental, dietetics, area medical officers, but they may not come under the operational governance of a community healthcare network. In the old West structure, we would have 9 community healthcare networks, 3 in Mayo, 1 in Galway, 1 in Roscommon, and 5 in Galway. And we organise those that there are 3 community healthcare networks aligned to an integrated care hub, which is part of the Sláinte Care Enhanced Community Care Programme. So it's the basic unit of delivery for integrated care, where you look at a coordinated approach to the delivery of integrated, coordinated services for a complex patient or even a non-complex patient, bringing everybody together. I suppose critical to the community healthcare networks is our GP colleagues, and working very closely with our GP colleagues in respect to patients and clinical care meetings where GPs and other disciplines are involved in those meetings. That's just a general overview, Tony.
Thanks, Mary. And John or Dermot, Mary said that described 9 CHNs across Galway, Mayo and Roscommon. What have we in Donegal, Sligo, Leitrim and West Cavan?
So there's 2, Tony, that are across Sligo, Leitrim, South Donegal and West Cavan. And Dermot, correct me if I'm wrong, but I think it's 3 that are in Donegal. Could be 4 actually.
No,
Donegal.
there's 4 in Donegal.
4 in Donegal.
All right. Okay. And there's a couple of points, Caroline, that I'd make about that question. One of them is that the CHN is the basic building block. So the reason I was asking John and Dermot to describe it, because where we've drawn the boundaries around our IHAs, they are matching up with CHNs, you know, so it's the basic building block of the structure that we've created. But the other one is a broader point, and it links back with the question that we had earlier on, which was about the MCANs, you know, so the MCAN is a structure within the CELTA group, and then the CHNs is a structure within community. And I guess one of the other hopes for the regionalisation of services, there'll be greater integration between the services that are provided across both, you know, on the basis that a patient that goes into a hospital today comes from community and hopefully will go back to community after they're finished in their hospital care. But with the way we set up our structures, they're quite separate, and even down to some of the language and terminology that we use, like CHNs and MCANs and so on. So there is a good bit of work for us to do just in, I suppose, in making sure that we're all speaking the same language, that we're all kind of, you know, working in similar ways in order to be able to deliver care in an integrated fashion.
And on that, Tony, a number of queries coming in to say that it's the CHN plus as well, and what that, how that changes or what that means in relation.
Yeah, CHN plus is a construct that that we've been using over the last while to try and help us, people like myself, to understand, you know, that there are some services in community that are provided across a number of networks, across a number of CHNs. They're not provided in every individual network, but they're provided across a number. So it's used in that sense, CHN plus. Whether or not we end up using that in the final construct, you know, we'll see that over the next 4 or 5 months.
Just Anne, I know that your hand had been raised there a minute ago, and apologies, we went back to our question. I think you were coming in on about...
I was actually going to introduce myself because I didn't actually. Tony introduced me earlier, but for the people who are on the WebEx, just to reflect that I'm covering Galway and Roscommon, that has I suppose a WTE of 8,700 direct employed staff and 1,600 voluntary agency providing services in the region, with a budget of over 1.2 billion. And I just wanted to reflect, I suppose I've come from a strong hospital background over the last number of years, but I've worked very closely with my colleague Mary Ward over the last few years on the integrated care programs, on the enhanced community care services. And going forward, I see this as a great opportunity to improve services for patients. We already provide really high quality services across our region in the hospitals and in all of the health and social care services in the community, and we want to build on that in terms of what we're doing. And in the very first part of the next few months, in case people are wondering what are we doing, there's a piece around due diligence and actually becoming familiar with the scope of services within the region, as well as managing the day-to-day operations, which is happening every day as we speak. And then obviously working as part of the regional team with Tony and colleagues in the change process over the next number of months to what the final structure will be from the 1st of March. So just to say, I'm looking forward to working with everybody, looking forward to engaging with staff across the services and also hearing the patient voice. And all of it is really about actually ensuring that we provide safe and quality services, and that we build capacity, because we know we have to build capacity across certain aspects of our services and work hard to do that with staff over the next 5 months. So it's really just to kind of say that hello to people really in the process, and I think Mary might want to do similarly.
Oh, yeah, sorry. Oh, I have my hand up there. Yeah, so thank you, Anne. I suppose I'm a compliment to Anne in that she has a very strong hospital background that I'm learning from her on. And while I have a nursing and midwifery background, I've spent the last 16 years as a senior manager within the community setting, most recently as the head of service primary care. So I'd have a strong community understanding, but as Anne said, working closely to get a better understanding of operations within the hospital setting, with the overall aim and objective that we would eventually become more integrated in our systems and processes so that we can deliver better positive outcomes or improved outcomes, because we do deliver very good services in our area, but improved outcomes for our patients in an integrated way. And similar to Anne, you know, it's about getting to know the staff in our area, getting to know the good work that they're doing site visits, but also getting a handle on the challenges that all our services face, in particular as we move into the winter, and together then supporting our services, both our heads of service and our general manager colleagues, to achieve that integrated care piece across the entire region, working with John and Dermot in that vein as well. So yeah, that's me. Thank you.
Thanks, Mary. I think Anya wants to come in as well.
Yeah, no, sorry, Tony. Just before we wrap up, I'm going to be cheeky, and thanks, Patricia Dever, for pointing it out. It's just with the season that's coming in, is to remind everyone, please go get your flu and COVID vaccines. If you're direct patient facing, especially, will you advise your clients as well? It's really important that they get their vaccines. Its flu is starting to rise. We actually are starting to see cases already coming in. So even though the weather is unseasonably good at the moment, flu is starting. So please take advantage, get your vaccines. There are clinics still running, or you can get it from your GP or pharmacy. And also anyone who's got kids, please get the flu. It's a nasal spray. It's done in a couple of minutes. It really is easy. My own kids have had it done, so it's really easy to do. Thanks, Tony. That's my plug. Thanks, Patricia, for that reminder.
Fair play to you. Fair play to Anya.
So, folks, I know we had said we were keeping this to an hour, and there are a significant number of questions that have come in. We will direct those we'll go through those and direct them to the people that we can come back to you directly on any questions that you've raised there that might not have been covered today.
Just from my own point of view, Caroline, just to come back again, I suppose we've mentioned this 5-month period on a few occasions, and it is important that we use it well to engage with people to come up with the best possible solutions to the management structures underneath the IHA. So we'll do that. But I also think that it's probably a period where we need to be in touch a little bit more as well, and have maybe more intensive communication. So I would hope that maybe this webinar wouldn't be just the first and only webinar, but that we might have further interactions like this as well as we go along. Now, it's not to replace all the communication that needs to take place, even at more individual department level or individual discipline level. We should be doing that, and we will be doing that as well. But I think to add to and support that, this could be helpful. So given the number of people that have expressed an interest and turned up this morning, and all the questions and everything, I mean, I think it'd be great if we were to engage in this way a couple more times over this 5-month period. Okay. Have any last questions, Caroline? Or
There were, I suppose, a question just in terms of how community knowledge is going to be incorporated into the population health planning for healthy and sustainable communities and longer term health protection.
I can come in on that, Tony, if you like.
Perfect.
Yeah, no, there is a process going on, I suppose, nationally in terms of the whole population health planning. It's part of this launch care. There's a lot of different groups being set up. It's linked in with the Department of Health. So that will be something that will be taken into account. And even indeed at a local level as well, we need to gather that. I suppose there's also community engagement piece, but it's there and it'll be in the plans. But it'll be that's to be developed in the next little while. Thanks, Tony.
And a final HR question just on how we're going to integrate panels that are in place into the new regions.
This might be one now for Maria, because I suspect it requires a level of expertise that I wouldn't have. Yeah.
Yeah, and I suppose just to say, similar to the earlier conversations, the HR function is in transition as well. So during the course of the next 5 months, we're designing the new HR operating model that will come into effect from the 1st of March. So as we speak today and as over the coming weeks, recruitment is continuing across each of the individual sites and each of the individual HR departments, and panels are continuing to be formed. But the objective is that from the 1st of March, we will have an integrated HR function across the region. So we'll be working on the design of that over the coming months. But for the moment, the status quo remains as is, and each of the HR departments will continue to try to work very proactively over the coming weeks to fill vacancies as they arise.
Yeah, and actually there's a question relating to finance as well, Caroline, and the same is true of finance, so that while the structures within finance have remained largely as they are for the moment, that will change under the new region, so it will reflect the regional structure. So we have Liam Fogarty has been appointed as the Regional Director of Finance, and there will be finance support then provided into each of the IHAs. We have existing finance then within the hospitals that will, and so on. So we will knit it all back together. And again, that's we're targeting the 3rd of March as the date for kicking that off. I think there is something else that's happening, and it's another example of something that's happening anyway while we're doing this restructuring. It is rollout of IFMS, and again, I suspect that most people on this call are probably familiar with it, and particularly if you're coming from a finance background, you certainly are familiar with it, I'm sure. But that will fundamentally change how we manage finance, because it'll provide us just with better information systems about our finances, and that's been rolled out in 2025 for our area, and it'll certainly fundamentally change how we manage finance.
And folks, I know we've kept you a little over, so thank you for bearing with us. There's one comment here just that saying that it would be useful for senior managers to attend HM meetings and CTMs also. That's something to.
And which
CTMs.
Okay, all right.
I'm afraid I can't elaborate on that, Tony. I don't know that one myself, so.
Yeah. Okay, is it just left for me to say thanks to everybody? So okay. Thank you for joining the webinar. I hope it was of some benefit. I hope we achieved the objectives in some ways, that you're a little bit better informed now than you were. I know that there'll be lots of questions that you're left with that you still don't have answers to, and they ask us that you continue to bear with us while we work that through. And we'll do our best to stay in communication through this method, but also in other ways as well over the coming months.
And just to come in there, CTM is clinical team meeting. Thank you for flagging that.
Thanks, everybody.
Now.